right? So what do you do with the intubation? So we know what we need to prep, right? We got all the stuff, all the people, all the supplies, all the meds, and then we're going to start pre-oxygenating them. So we're going to make sure that they are getting the oxygen and their stats are good before we take away everything and intubate, right? So we're going to make sure that we are pre-oxing, and then we are then going to apox, or provide apneic oxygenation. This is what you're providing when they are getting the paralytic, right, and sedation, right, because they're going to get sedation, and then they're not going to be, they're not able to maintain their airway, right? We do also do want good positioning, but the apox is important because it's providing O2 to lungs that are not breathing, right? It's providing, the blood is still being delivered to the lungs by the right ventricle, and they're still picking up oxygen. So you want them to pick up this oxygen here, right? So if we calculate, like if you're using about 250 mLs a minute of oxygen, your body's using that much. Normally, all of us right now have about 3 liters of residual capacity that we can work off of. So if you calculate 250 to 3,000, you got about 3 to 5 minutes. That's why if you fall into the ocean right now and you stop breathing, you're underwater, you got about 3 to 5 minutes before you're really in trouble, right? You can still use oxygen. But then what if you have like an effusion on one side, and then you're in pulmonary edema, and you got COPD, and you got bronchospasm, and then you have a pneumonia on the right side, and you have a tumor on the left and TB on the right, and you have all these things are getting in the way of your residual capacity, your reserve that you've heard people say, oh, they got no reserve, right? They literally have no reserve to work off of. Now they have 250 mLs or 100 mLs, right? And they're not using 250 mLs a minute anymore of VO2. They have a fever, they got TB, they got all this stuff working. It's not 250, it's 500 or 800 mLs a minute of oxygen they're utilizing. So that 100 cc's of reserve is like 5 seconds, right? So you want to make sure we are providing as much oxygen, whether it be 5 seconds or 5 minutes, providing oxygen at all times to the lungs, right? And how do you do apox? All you do is throw nasal cannula on them, right? And you just crank it up to 11, right? You're going to go all the way up, not 11, to more than 15, right? All up to 25 to 30, turn it up to what's called flow. And again, it will be the loudest thing in the room, but it will be providing oxygen, and it's going to be something there to help prevent any kind of complications. Okay, so apneic oxygenation is important for this reason. If they're already on vapotherm, then you pretty much have it. You just crank to 40 liters, 100%, you're done, right? If you want to be fancy and grab the high flow cannula, the green one, you can do that too, but all you need is a nasal cannula, right? And again, it's in the crash cart, third drawer. Okay, so it makes to make it extra spicy, right? So you provide that oxygen, but what if you provide some PEEP behind it? So that's what this BVM can do. All you gotta do is just set it on their face, and it's gonna the oxygen itself will inflate the lungs, right? The more PEEP valve you apply to it, the better, right? So RT knows what they're talking. If you ask them, hey, you got a PEEP valve attached to that? It's like, yep, I got the PEEP valve there. They can crank it all the way up to 20 of PEEP, okay? And all it's doing is providing a lot of positive pressure, opening up more alveoli, providing more apneic oxygenation to help the patient make it through this intubation. All right, and then other things we probably consider before we, once we're ready to go, meds are in, is making sure that the position is optimal. The more obese they are, the more difficult it is to get good ramping, right? But otherwise, they might ask for a little towel under the top of the shoulders there. You want to make sure they're like in a sniffing position. That's the ideal plane. Usually their face should be parallel to the ceiling. It's kind of the idea. Okay, so here's this residual capacity I was talking about as well. That's what's there. If you just stop breathing right now, that's what's there inside the lungs to work with, right? And then it's time to intubate. So we provide apneic oxygenation, nasal cannula, and then we make sure that we get to the right place. And what color should our capno check turn to make sure we're in the lungs? It should turn gold, right? Gold is good. And then we visualize it going through the cords to make sure we get capnography to make sure it's in the right place as well. And of course, we're going to grab some blood pressures and vital signs, make sure we're still hooked up to the monitor to make sure there's no complications afterwards. All right, so here's an idea, here's a picture of the sniffing, or a video of the sniffing position. So you see how it opens up the airways when they lift their lungs up, when they lift their head up to the ceiling. Vitals pre and post, so we got our vitals pre to make sure our blood pressure is good, up to at least 110 to 120 systolic, because we know the medications are going to lower it, and the ventilator is going to lower it with its positive pressure ventilation inside the chest. So we want to make sure the pulse ox is good, all right? You want to call out the numbers if need be, make sure, hey, you're 87%, hey, we're 80%, right, 72%. That lets them know like we should stop, messing around and try to give them an oxygen to back up again. Okay. You can also turn up the volume on the monitor and get it to beep. I'll demonstrate this afterwards in case I mess up. But the other thing you want to get besides having a pulse ox pre and post is to make sure we have a blood pressure pre and post, right? Make sure we're setting it to every 3 minutes. It's going off, so we know that the meds could cause it or the positive pressure ventilation could be causing it. And the heart rate. So you have a heart rate like this up here, and then all of a sudden you start getting pauses. That's going to start, you're going to start hearing the clenching of anuses around the room. What's that? That's a bad situation. That's someone that check for a pulse. Oh, we got no pulse. So that could be a situation. What's another way someone doesn't have a pulse? CO2. There you go, end tidal CO2. That's going to let you know right away, oh, my end tidal CO2 after intubation was 42, and then all of a sudden now it's like 30, 20, 14. That's someone that's losing their pulse, right? There's no way someone's blowing off their CO2 that fast. Right, they'd be breathing like 60 breaths a minute. That's not gonna happen. Okay. Also, end tidal CO2 is going to show definitive placement of your ET tube. Right. It'll show you an esophageal trend. Right. It might be going down to nothing, or it might show you this waveform, which indicates what? You're in the right main stem. Right. So that's another reason to have end tidal CO2 in place. Right. Your heart rate might be increased because we have what medication was given and we didn't give sedation? The paralytic. Which one? Because one lasts 3 minutes, one lasts 30 to 45 minutes, right? So the rocuronium was given and we didn't have sedation to support it, right? So rocuronium plus no follow-up sedation. So that's the idea behind your vitals, pre and post. We want to make sure each one of these are in place. We don't have them disconnected. Make sure we have good pulse ox reading, good perfusion, whatever you need to do to get a reading. So if you listen to the pulse ox on the GE monitors do this as well, the pitch is actually higher when you have a high pulse ox, and it's lower when you have a low pulse ox. So whenever it's focused on the airway, you can actually hear it in the background going off, right? So there's an idea of what it sounds like. So you say 98 versus 99, just hear the difference in tones. The 99 was higher pitch compared to the 98. Obviously, when you start getting the 93 and 91, it's going to be even lower. All right, what to do next? You got your patient tubed. So you got to verify it's in the right place. You got to make sure it's about 2 to 4 centimeters above the carina. The carina is like one of the magic eyes from the 90s. You got to kind of cross your eyes, get really close, and bring your face away, and you might be able to see the carina, right? You can play with the settings and try to increase the contrast. You can invert the colors to try to make sure that you can identify that your ET tube is there. And it's good practice to look at your X-rays so you can see that it's maybe migrated out or migrated in. Right? Another way to know that it's migrated out or in is to check what? The waveform could tell you, yeah, if it's migrated in, you can see that it is that little right main stem pattern. If it's migrated out, you're not going to see a great waveform at all, right? What's another way you can tell it's in the right place, that it's in the place it should be at least?
Breath sounds.
Breath sounds, yep. You hear it diminish on the left, right? That means it might have migrated down into the right, or they developed an effusion or something. You can look at these numbers right here, right? These numbers are your centimeter markings. It tells you how many centimeters it's in, right? So they intubate them and they got an X-ray confirming it's at 22 centimeters. It should not change, right? Just like your OG tube. It probably has not changed, right? If you're looking at your eyeball, your OG tube, and it's 55 centimeters, and later in your shift or the next shift it comes and it's at 30 centimeters, it's obviously migrated out, right? So to verify tube placement, you go back, capnometer or capnography is going to make sure it's in the right place. Auscultating, 5 times, 1 time over the gastrum is only 80% accurate. So 1 in 5 times it fails. So that's why having end tidal CO2 is the gold standard. And then ET tube lip line, making sure it's at the right place, right? And I think on the next slide we talk about how to estimate what kind of lip line it should be. You'll hear lip line thrown around, but the actual word you should be using is teeth line, because people's teeth don't change, but there's these things called like lip fillers, and they have these little, what are they called? They eat spicy things, and what's the word I'm thinking of? Not the Carmax. What am I thinking of?
Like the plumpers.
Yeah, so they're going to plump the lips. So not that your patient's plumping lips, like right, every time. But that's the idea, is that the lips can change, or the teeth don't. So you want to make sure you have the teeth line, right? And people can have angioedema, people can have upper airway swelling, so we want to make sure we have teeth line. So the teeth line is at 21 centimeters or 23 centimeters. So you know exactly where the tube is. And don't tape over it multiple times. Make sure you're nice and you pay it forward so we can identify where it's at. And this really probably should be changed to a more secure ET tube lock. Yes?
We're talking lip line. Are we talking like when the lip starts or when the lip ends?
So that's why we say teeth line.
Exactly.
Instead of saying lip line, like do I get like a ruler? Do I flatten it? Like what do I do here, right? So you want to be looking at the teeth line. That's where it should be at. Okay. And X-ray you mentioned, about 2 to 4 centimeters above the carina, right? So this little space right here is the carina where it bifurcates, right? And goes down to left and right. So it should be about 2 to 4 centimeters above that. Right? You're going to place your OG tube to make sure, and then get an X-ray. Hope you get a 2-for-1. Hope you don't forget and get an X-ray. Oh, ET's a good place. Oh, forgot my OG tube. All right, so you want to get both of them using that post RSI situation. Do you place NG tubes?
Sure.
Do we place NG tubes? No, it causes nasal colonization of the ET tube, which is not good. Right? Also, you want to make sure that RT has secured the airway before you start getting there and start throwing your OG tube down. Right, you want to make sure that that is in the right place. Sometimes they might have to deflate the cuff for you if it's really inflated, or maybe they have some different anatomy so you can get it down there. But you got to be careful, because if you're deflating the cuff, you might be going right in the lungs with your OG tube too. Okay, you want your IV sedation, right? Propofol is usually our go-to because it wears off in 5 minutes if we don't need it. And you want it especially if you're giving a specific paralytic, such as which one? The one that lasts 40 minutes, rocuronium. And initial vent settings. So this will get you by about 90% of the time, is just think of all fives, right? 50% FiO2, rate of 15, volume of 500, and PEEP of 5. That usually gets you by, okay? But again, we got to think about it, because we talked about ABGs. Like if you intubate a DKA patient, breathing 36 breaths a minute, 15 rate is not going to cut it. Or if you have a grandma that's 4'7", 500 cc of tidal volume is a lot for that, right? So we want to make sure we have an ideal tidal volume. So we've got to calculate that afterwards, okay? You might want a higher rate again if they were tachypnic pre-intubation, because induced hypoventilation is going to cause mixed acidosis and going to drop your pressure real quick. And then no PEEP might be needed if they're hypotensive, or really, really low PEEP, a 3 PEEP maybe. And then if they are CHF, you can even start at 10, right? Because we know that 10 of CPAP is great, so 10 of PEEP must also be great. So we can start them a little higher up if they're CHF patients. We got to be careful of what dropping if we increase the PEEP. The blood pressure. And then 50% may be all you need for someone that's just for airway protection. Like they're a stroke patient, you're intubating, they don't have like an oxygenation issue, they just have a neuro issue. Okay? And on our ventilator, there's all kinds of knobs and twisties we can do to fix ventilation or oxygenation, right? So ventilation is going to be affected by which two values can we change? Respiratory rate or tidal volume. And then oxygenation can be changed by changing the PEEP or the FiO2. And of those 4 parameters, right, they will affect ventilation, oxygenation, depending on which one it is, but there's overlap between which ones will increase the pressures inside my chest, right? It's one of each, basically. So we know that tidal volume and respiratory rate will change my CO2, but which one of those will change the pressures in my chest? Tidal volume, because I do 300 cc's or 500 cc's of pushing air into my chest. If I do 500 cc's, that's going to increase the pressure in my chest, right? So we might consider coming down a little bit. And then on the flip side, if we're trying to improve oxygenation, and we could say, well, I can either increase the FiO2 or increase the PEEP. And I got to figure out which one's going to increase the pressures in my chest, because I don't want the pressures to get too high. So which one of the two will raise the pressures in my chest? The PEEP, right? So PEEP will, in red, raise the peak pressures and plateau pressures, and the tidal volume will raise the peak pressures and plateau pressures as well. So we're going to dive into that in the next section. All right, so just a little anatomy on the ET tube and cuff. All right, so ET tube ideal. Usually, you'll hear people say, oh, 7.0 for women, 7.5 for men, but really it's based on their height, right? Their ideal, their birth gender, and their height. That's going to tell you what kind of ET tube depth should be recommended, and also what kind of tidal volumes to grab, okay? And ET tube size, for that matter. Usually, you can get away with 8. The smaller the ET tube, the higher pressures will be, because it's a tiny, tiny straw. but also it can be with a, what else? It could be it might have to do a bronchoscopy. You can't really do a bronchoscopy through like a 6.5 ET tube. So you might want to consider that. That's something to consider when the provider chooses what size ET tube they want. Right? Again, the lip line or the teeth line from the central incisors. So it's not the molars. If they have gums, they're just gummy McQueen, then you just gotta choose the gum line. All right? All right, so then again, it depends on 19 to 24 centimeters. In pediatrics, there's the same equation for the AA gradient. It's your age divided by 4 plus 4. But other than that, it's going to be a, we can estimate what kind of ET tube size and depth based on their height, right? Because if they're a little short king, they might require a little not as deep of an ET tube. Okay, so what else? So the ET tube cuff. So the cuff, we mentioned, is important to inflate so that we don't get all these secretions building up and making their way down, causing a what? A ventilator-associated pneumonia, right? So we want to make sure the cuff is inflated at all times, not too inflated, because then it's going to start breaking down the tissue, and that's going to cause, holes to happen, which is not good. Okay, it's going to seal the trachea so that we don't get, secretions down there. Also, it's going to make sure that we give the volume we say. Right, you don't want to give 400 cc's, then some of the volume just to escape all the way out. Right, you want to give 400 cc's every time. That's what we want. Okay. And ideal pressure is about 20 to 30 points, and the RT should be checking this every shift to make sure that it is in the right zone. Okay. What else? So what they say is there's no like 10 cc's or 7 cc's or 12 cc's. It's called what's called minimally occlusive pressure, just enough so that you don't hear the patient talking to you. Right? You should never hear your patient talking to you or hear rattling of secretions. That means their ET tube cuff is deflated or it's blown, and they probably need to get another intubation. Okay, so the cuff can lose cuff pressure, and it can rupture. They can bite through what's called the pilot balloon. So here's the end of the pilot balloon, but here's the pilot balloon right here. Right, we put in air into it if we need to, and if the patient is biting, they can bite through it. Right. Sometimes you get manufactured defects, and the cuff can deflate. So these are things that can happen that we have to be alert to. Okay, and there can again be too much cuff pressure. That's where it can eat away at the tissue, eating away, and cause malacia of the tissue, tracheomalacia, and cause a fistula between the trachea and the esophagus, or between the trachea and the big artery that runs next to it, the innominate artery, and that's not a good situation. All right, so we want to make sure that we are keeping track of these pressures, which RT is doing. Okay, they're making sure it's the minimally occlusive pressure about the 20 or 30 point range. All right, so acute complications. We'll talk about more complications that happen in the first day, second day, third day on our next lecture. But this one what can happen immediately if we tube the patient, they go right down to the right main stem. We can know because of the end-tidal CO2 waveform, but X-ray is going to confirm it as well, and we're not getting ventilation of this other lung, so we have to do what? Pull it back, right? So RT knows how to do this, and they'll let the provider know and say, come back 2 centimeters or 4 centimeters, and we're going to keep note of what that marking was. Okay, so right main stem intubation is a possibility. Esophageal intubation, there's an example of esophageal intubation. On end-tidal CO2, you can clearly see that I'm not getting CO2. If they drank a Diet Coke, sure, maybe the first 3 breaths, 4 breaths, but after that, it's going to go down to nothing. Okay, and glide scope is going to help prevent this. So we use a glide scope intubation. We can visually see it does not go to the esophagus, it goes through the cords. Right. Trauma can happen with intubation. They can go through they can cause trauma to the trachea, trauma to the bronchus. They can cause a lot of problems. They can lead to a pneumothorax, see all the subacute emphysema over here. It can lead to excessive bleeding. It can lead to a lot of problems. So we've got to be aware that it's not a low-risk procedure. It can still have complications. Okay. And then the airway could get swollen. So sometimes you might hear nurses say, oh, they were a traumatic intubation or a difficult intubation. That usually means it took more than 2 times to get them tubed, right? And that can clue you in for the weaning process because you're not just going to take the tube out because their airway can swell shut because it's inflamed because it was manipulated so many times to get them tubed, right? So we talk about that next time when we talk about how to fix a tube that was a difficult intubation. All right, and we talk about pneumothorax, and then just failure of intubation, right? So they can't get it in. So what do? You have to call an expert. You call who? Anesthesia is your kind of your go-to. All right, they're not always here, unfortunately. Sometimes they go home at 6 o'clock. So you could call them in. There's always an anesthesia on call, right? So you get into this second attempt, third attempt, you're probably calling the house soup to call in the anesthesia, or they might be here for a case already. And also the ED provider after hours is going to be one of your experts as well. And again, that's when you want the crash cart nearby. You want RT getting the difficult airway kit. ED should be grabbing the cric kit, so we can go ahead and we can do a cricothyroidotomy if we need to. Okay, so applying cric pressure is something we might be able to do as well to help visualize the chords. So there's an idea of with, without. So here's without, with, right? Without cric pressure, with cric pressure. So you can see that it's much easier to visualize the chords when you can push it down. And here are the chords as well, right? So this airway is pretty swollen. All right, so they're visualizing it, and they're going to be advancing the ET tube right through the chords. That way they make sure they're not an esophageal intubation. They visualize it going right through. Okay. All right, so other paraphernalia to think about. So the vent circuit, this circuit right here, that is something that RT maintains. It gets changed PRN. Okay. They did studies comparing like every 24 hours, every 3 days, every 5 days. They just said PRN, right? Because the more times you interrupt the circuit, the higher you risk to get of what? Contamination, right? And contamination can make its way into the ET tube, into the patient's lungs, and cause a VAP, right? And also we suction. We need to suction the patient's lungs every 2 hours. So how do we do that? Because in the past we got a 14 French catheter, right, for the kit, and we had nurses get sterile with quotes, right? So sometimes they were sterile, sometimes they weren't, but this kind of guarantees that. So we attach this inline suctioning device. It's just a 14 French catheter. So that gets disconnected. We can always use a 14 French catheter if we need to. If that's connected to the circuit here, so here's my ET tube right there. Here it is in the circuit, and that attaches to my suction, right? And I'm able to then suction the patient every 2 hours. Okay, and then some pro tips. We want to make sure that this is always in the off position when we're done, so it doesn't, you don't leave and the patient leans on it and it's sucking. You're delivering FiO2 here, but then it's being sucked out here because you left the suction on. All right, we want to make sure the little device is turned over to the off position. And of course, turn it to the on position before you suction. You don't want to be all the way down the airways. Like, let me undo this, right? So then the HME, so the heat and moisture exchanger. So all it is a piece of cardboard folded up from someone's Amazon packages. That's all it is. There's nothing fancy about it. It's just, and by the miracle of physics, all it's going to do is it's going to heat, and it's also going to humidify the air that's going into the patient, right? So it's a great device because it will prevent airway drying and redness and bleeding and secretions drying up, because you want those secretions to come out. Because when you put this ET tube in, they no longer have the ability for mucociliary clearance to be able to cough up the secretions. So that's the reason why we suction them. If we're not humidifying it, it's going to be difficult to suction. So I want to make sure that that is in place. If they really need to get a lot more secretions out, they got really, really dry secretions that are what are called tenacious, really, really, really thick, right? We can use what's called a heated wire circuit. And this really, really provides an extra humidification, more than the cardboard from my Saturday morning Amazon splurge. Okay. What else? So ET tube holder. So we have a little tape that can be used here. You see this tape on Grey's Anatomy. It's like, it looked like Scotch tape that got off the desk at the nurse's station. They tape the ET tube in place. And then you have actual, ET tube tape, which is very, very, it's like silk tape. It's very, very strong. And then we have these anchor fasts, which are a lot more comfortable. Okay. And you can zip tie the ET tube in place, so it's not going to go anywhere. And then what else? So we got the ventilator itself. So we'll talk about the ventilator in the next section, but here you want to make sure your vent's plugged into the red outlet in case the power goes out.